And so, yes, thank you so much, Teresa. My name is Karen Sahota, and my background actually is 25 years in county employment. I retired from a large county under MHSA. I was the administrator, and actually this year marks 10 years as part of MHSA with our counties. So now BHSA has been just a big part of my life for the past decade, and I'm really excited to talk about this project. When I retired from the county back in 2000, I was called at that time to oversee the thought of a project called Psychiatric Advanced Directives. So my task was to gather counties on board to really test psychiatric advanced directives in California. And so that's really what I'm here to talk to you about today. So in phase one, 7 counties banded together, and we have a collaborative psychiatric advanced directive multi-county project. And I'm going to go through. Okay. So phase one for us really became the build, and I'll talk to you more about what that means. But we really looked at, with the help of our 7 counties, really identifying the need for a digital platform. And so the build is the digital platform. And so I want to talk a little bit about directives in California. And many of you may not know about the differences in our directives, but we do have different directives, and each one of them acts individually, or you can have them combined. But psychiatric advanced directives are the ones that we're working on our project, and they specify preferences for a mental health or substance use care, or what we call behavioral health. During a behavioral health crisis, it can include treatment preferences, medication preferences, what facilities to avoid if possible, how to de-escalate, even so much as, hey, I have children, can someone pick them up from school? It can be an instructive document with preferences only. It can be a document that has a chosen durable power of attorney, or it can be both. And that's what a lot of folks don't realize in California is both are legal. And it really is a document that transitions throughout an individual's lifespan. So think about a 19-year-old, a 21-year-old who may have their first psychotic episode. They're not looking at a medical advanced directive. That's something that I have. I am a person of an older age. And for me, our next one is that medical advanced directive, which really is specifying medical specific care during incapacity. You can include mental health preferences within an advanced healthcare directive, but that is really only active if you've lost capacity. And it's also typically not used through the lifespan. It is used in, you're getting medical care, you're checking into a hospital. And so then we go to the third aspect of directives in our state, and we have a POLST, which many of you may know as your pink form. My 92-year-old dad had a POLST, which was a DNR form, and really identifying how to relieve pain and suffering, and of course, your do not resuscitate. So those are the different aspects of directives, and we really chose to focus on the preference aspect of psychiatric advanced directives. And why? Because what was missing in California? There's a lack of follow through in hospitals and medical professionals on a current law, and that is your 42 CFR. That has been around for decades. And a lot of hospitals will ask, oh, do you have an advanced directive? In California, under advanced directive includes psychiatric advanced directives. So technically, all hospitals should be asking, do you have an advanced directive that includes or including a psychiatric advanced directive? Also under AB 1029 back in 2023, we also under probate identify that you can have a standalone PAD. There is a lack of understanding on what a PAD is and how is it useful. There's a lack of access to PADs or any directive for that matter. There's a lack of training. There's a lack of a usable registry. And as we were looking at legislation, our Secretary of State, who maintains that registry, flat out said, we have a metal file cabinet and I'm not upgrading it. Well, that doesn't help anybody that's looking to use their directive. And also understanding that there's a lack of understanding, at least restrictive options, especially when we're considering conservatorship. Why are we not looking at self-determination and autonomy? So in California, we also identify that PADS are a perfect fit across the continuum of care, especially now when we look at Care Court, we look at SB 43 and Prop 1. It fits seamlessly in all aspects of our mental health system and throughout just life in general. It is great for our 90-day reach-in, which is a pilot within California. It is going to be federal. I know California is piloting it. Our assisted out, AOT, these are all items that most of you are familiar with, our AOT, our FSP, our crisis res, supportive housing. It supports inpatient and outpatient stability, our early intervention or our early psychosis, our TABE population, mobile crisis, 988, even 911 dispatchers, and also our dual diagnosis. When we looked at substance use and IDD, our platform has information on I have autism. I'm on the autism spectrum. I have a traumatic brain injury. So I am a veteran and I have PTS. And so really looking at that fit across our entire spectrum of care. So we really looked and sat down and thought, what are the benefits of having a digital pad? And really it's improved efficiency, so that real-time accessibility, improved quality of care, so utilizing a person's preferences. Why are we guessing? Why are we just making things up as we're working with individuals? Why are we not looking at their preferences? They know themselves best. Timely information for if a person has lost capacity, or timely information to help prevent the loss of capacity, de-escalating a situation. And increased care coordination, as I mentioned before. Can you imagine law enforcement being able to tell a hospital, hey, this person has a PAD, or a hospital being able to say, hey, let me look at who is your preferred contact, let's give them a call. So really that easy accessibility to preferences and immediate connection to a person's preferred contact. So 7 counties, and you'll see on my chart here, I have Alameda. Alameda is our 8th county. They're joining us in phase 2, which actually starts on July 1st of this year, as in just a couple weeks from now. Phase 1 is winding down. But our 7 counties banded together to create a collaborative project, which I'm going to tell you, in my now 30 years working with counties and in county mental health, and 10 years in MHSA world, this is by far the most collaborative project I've ever worked on. And all of these counties have banded together in the same direction, really looking at best practices and working together seamlessly. And I think that's why we have been very successful in really appropriately utilizing MHSA funding. We created a template that helped standardize the language of psychiatric advanced directives. Looking at 6 or 7 templates from around the nation, having our work groups really fine-tune what that would look like, creating a facilitator training so you have that peer-to-peer interaction, creating a replicable and sustainable technology that provides individual consent on a HIPAA-compliant platform. We are looking at legislation. We looked at it last year under AB 2352, but stopped the bill, as we really want to fine tune what our ask is. Probate already has a lot of information, but for example, we really need to work on the Secretary of State and understanding that we need a better place for a registry and or access, and really looking at how we can incorporate all directives. And outcomes driven. Evaluation. That is probably one of the worst things that ever happens in MHSA. And we ended up with both RAND and BBI. So we've had a lot of evaluation just on the build. So very excited about that aspect of it as well. And I'd like to show you now what our 7 counties created. It is, I think, beautiful. When I first saw this, it brought me to tears because I'm so proud of the effort. But let me play this for you.
Psychiatric Advanced Directive. My plan, my voice. Proactively create a plan for a behavioral health crisis. Getting started is easy. A PAD can be created with a free account through the secure web-based platform, providing guidance along the way. The dashboard serves as a centralized hub for creating and managing PADs. The first part, Crisis Directives, focuses on the crucial details that should be shared with professionals and others providing support during a crisis, like health history, communication preferences, and who to contact during a crisis. It also includes anyone who should not be notified. Completing each section encourages individuals and guides them to the next section. Treatment directives allows individuals to share supplemental information for professionals to consider when providing care, like instructions for medications, accommodations needed if receiving inpatient care, as well as any gender-affirming and reproductive health considerations that professionals may need to factor into treatment. The PADS platform will be available in multiple languages to ensure broader access for more communities. Once completed, it can be previewed as others will see it. Individuals can see what their PAD will look like when accessed by professionals and preferred contacts. They'll always have the ability to choose which professionals can access their PAD. The platform makes it easy to collect signatures needed to make it a legal document. It's as simple as reviewing the PAD, confirming who has access, and adding a signature in-app. As a professional, you will have the information you need to help inform decision-making, reduce liability, and enable a positive outcome for individuals like Richard. Research has shown that utilization of PADs can contribute to lower rates of recidivism in hospitals and jails. The PAD platform ensures key information about an individual's needs during a crisis is quickly accessible. Professionals can search for and find active PADs. The most important information is displayed at the top, and more details can be reviewed quickly below. You'll be able to see key information such as diagnoses, how to de-escalate, and how to communicate. PADs can be shared with an individual's preferred contact, who can provide support and advocacy on their behalf. The PADS platform helps individuals plan for behavioral health crises by voicing their treatment preferences, as well as empower advocates and professionals with information they need to offer more effective care and support. Psychiatric Advanced Directives, empowering and encouraging individuals to make decisions about their well-being. Learn more at padsca.org.
So the build was evaluated by the Burton Blatt Institute, which is one of the leading institutes for disability rights. And they're also one of our evaluators for this first phase. And we created, so part of what they've evaluated, and actually the full evaluation report will be due to CBA, the Commission for Behavioral Health. My goal is to get it to them in July. And then it will be public. You can read, I think their report is actually about 137 pages. But some of the key points that we took away from the build is that the registry was created using an iterative and inclusive process that integrated feedback from multiple groups. We use peer support specialists, family members, behavioral health professionals, county employees, law enforcement, hospital staff, first responders, and other stakeholders. And I'll give the PowerPoint to Teresa so she can pass this out to you. So I'm not going to read through every single comment. You'll have that you can read later. But one of the other aspects is the platform was praised as an improvement over paper forms due to its accessibility, design, and interactive elements. Some of our stakeholder quotes was, as peers, we've done a really great job putting this together. I think we've had a voice in almost every step. Another one is, We find that the PADS technology platform developed in phase 1 has increased individuals' knowledge, understanding, and acceptance of PADS. Well, actually, I'll go into the next aspect. So now we roll into phase 2, and phase 2 is what we call a rollout. We thought we would be, having everybody have the information already on PADS, but the build took some time because we really wanted to do it right. And we spent a long time in our work groups really creating that beautiful digital website that we have now. And the product now we can fully test in phase 2. So our phase 2 goals now with our 8 counties, including Alameda, and we do have room for 7 more counties, just so you all know. I know with DHCS removing the constraints on your prudent reserves, there is funding available to join our project. It was originally innovation funding, and Prop 1 prevented some additional counties from joining because of the change in funding and the removal of innovations, but any county can join and it doesn't have to be innovation funding. So just putting that out there, because we obviously would love for this product to be in all counties, because eventually we are asking the state to take this on. So we are looking at another 4 years, and we're looking at training on how to complete the PAD, training on how and who can access it. So creating MOUs and very fine-tuned relationships with law enforcement who currently doesn't have to ask. So we want to identify and work with law enforcement to find out what the best practices are, working with hospitals to understand they should be following 42 CFR, and how can they incorporate that into their daily emergency department routine as well. Community-wide education, understanding the importance of PADS. And then we're going to evaluate. We're going to look at the reduced number of crises that result in incarcerations and in hospitalizations by utilizing PADS, the number of PADS created, the number of PADS accessed, and the increase in care coordination. We also want to look at the positive revenue impact. A lot of counties still don't understand that peer support specialists can bill. You can bill to create a PAD. And so we really are going to be showcasing that within our next phase as well as reduced costs for hospitalization, reduced lengthy calls for service for law enforcement, and reduced unnecessary incarcerations. And then our phase 2 training, we already do a facilitator training that was created in phase 1, and the peer-to-peer facilitation has been incredible. Really just training individuals why it's important for their voice to be heard. It's just been incredible, the discussions that our peer support specialists have had. We're going to create new trainings for law enforcement and first responders, new trainings for our court systems, especially care court, probate, and conservatorship. Again, this is a least restrictive option. Training our crisis teams to provide that care coordination, how to de-escalate the situation utilizing someone's PAD, and if somebody doesn't have a PAD, how to refer them to get a PAD. And also the same with our emergency departments, really understanding their responsibility under 42 CFR, training them how to ask, how to utilize a PAD, and again, if somebody doesn't have a PAD, how to refer them to get a PAD. And with that, I'd like to open it up for questions. That was